This is Dr. Rajiv Agarwal, Professor of Medicine, Indiana University School of Medicine, and staff physician at the Rodebush VA Medical Center, both in Indianapolis, Indiana, USA. I'm going to present to you the diagnosis and treatment of heart failure in patients on dialysis. This is a presentation which I hope will help you when you return to your patients to take care of them. This is more of how to do this rather than reviewing the literature in great detail. I'll start with a case. It was 11 p.m. and I was driving home on a Saturday after a grueling weekend call at the hospital. I get paged by the renal fellow informing me that a homeless dialysis patient was feeling short of breath, nothing more than usual. After dialysis, the shelter was closed and the ambulance left her at the hospital. She usually requires 5 liters of oxygen, but she now needs 8 liters, but looks okay otherwise. I was a bit puzzled. I thought, why the ambulance dropped the patient at the hospital simply because the shelter was closed. Next morning, I walk into the dialysis unit and see Kalisha Davis, which is not a real name, a 26-year-old black woman sitting in bed struggling to breathe, an anxious woman with rales at basis, jugular venous pressure to the angle of the jaw, and a hyperdynamic precordium on physical exam. Auscultation revealed a summation gallop without murmurs. There was no pitting pedal edema. Why is she so short of breath? Does she have heart failure? Well, heart failure is a clinical diagnosis. Symptoms, signs, investigations, and response to therapy is what makes the clinical diagnosis of heart failure. This slide lists the symptoms commonly associated with heart failure. Shortness of breath is a common manifestation of heart failure. We grade it according to the New York Heart Association, or NYHA. When the patients are short of breath at rest, we call it NYHA 4. When they have shortness of breath with activities of daily living, it's NYHA class 3. When they have dyspnea on exertion on more than usual activity, NYHA class 2. Class 1 is asymptomatic. Paroxysmal nocturnal dyspnea and orthopnea are cardinal manifestations of heart failure. Nocturnal cough is quite common. Swelling in the feet, mostly in the evening and least in the morning, is also seen. Nocturia occurs in patients who have kidney function, but obviously is absent in patients on dialysis. Our patient had jugular venous pressure, left ventricular third heart sound, and rales, all major manifestations. She also had a displaced apex beat, tachycardia, hepatomegaly, and bilateral pedal edema. They're all signs that suggest the presence of heart failure. Most people have access to a chest X-ray, and if a chest X-ray shows cardiac enlargement or pulmonary venous hypertension, it strongly suggests the diagnosis of heart failure. Pleural effusion can sometimes be seen, but it also can be seen in other conditions. We can do echocardiograms, we can do lung ultrasounds, other tests, and they are common. But chest X-ray I mentioned because it's available to everyone in this room. The term ex juvantibus comes from the Latin ex adjuvantibus, from that which helps, which in medical context refers to processes of making an inference about disease causation from an observed response of the disease to a treatment. In this case, we are talking about a response to therapy. The Framingham Heart investigators describe this as a weight loss with diuretic therapy of more than 4.5 kilos over 5 days. So approximately, if you're giving a diuretic and losing a kilo per day, it's considered a diagnostic test for heart failure. Now, this is something that will be very relevant to our patients because although diuretics don't work in dialysis patients, we can use this as a test to diagnose heart failure or volume overload in our patients. None of the classification systems for heart failure do justice to the patients on dialysis, and therefore the Acute Dialysis Quality Initiative 11 work group came up with their own classification system. This is a rather complicated figure, but illustrates that patients are classified from class 1 to class 4 NR. Every stage, 2, 3, and 4, has a R or NR attached to it. To explain this better, I have created a table which I will go over. At baseline, we assess the symptoms of the patient and classify them as class 1, 2, 3, or 4 based on New York Heart Association criteria. Class 1, as you know, are asymptomatic, and these patients have to have echocardiographic evidence of heart disease, such as chamber dilatation, hypertrophy, regional wall motion abnormalities. Class 2, 3, and 4 have the usual meaning. Subsequently, we assess their response to ultrafiltration or renal replacement therapy. If they improve, then we call them a class R, so it becomes a 2R, 3R, 4R. If they don't improve with renal replacement therapy or ultrafiltration, we simply attach the letters NR behind the stage. So I asked the fellow, why is she short of breath? Severe mitral stenosis, replied the fellow. I could not believe the diagnosis. I listened to her heart again, placed the bell of the stethoscope at the apex, laid the patient in the left lateral position. There was no diastolic rumble with presystolic accentuation. The apex was not tapping but hyperdynamic. This does not look like mitral stenosis. What would you do next? Well, the next question you ask is, what is the etiology of heart failure? The two most common causes of heart failure are hypertension and coronary artery disease. Of course, patients can have valvular heart disease, arrhythmias such as atrial fibrillation, and rare, which means that it's often seen on exams rather than in the clinic, like diseases like amyloidosis or Fabry's disease that can affect both the heart and the kidneys. So hypertension is quite common, and coronary artery disease is the next commonest. Now, it turns out that if you have coronary artery disease in a patient with on dialysis, then you have to be careful. If they have low ejection fraction, triple vessel disease, and viable myocardium, they may benefit from a bypass surgery. So just because they have low EF, it does not mean that you think that it's all dialysis. A cardiology consultation may be useful. Now, in valvular heart disease, this patient obviously didn't have mitral stenosis. Aortic stenosis happens commonly in people who are elderly, and they might be candidates for transcatheter aortic valve replacement. The arrhythmias, such as atrial fibrillation, may be quite common in these patients, and the debate is between rate control versus rhythm control. And of course, these patients may not have the atrial kick that they need, and the rhythm control may be paramount in some patients. Amyloidosis and Fabry's will leave. The patient had an echocardiogram a few months ago that showed no mitral stenosis. A 3 mm gradient was likely because of asymmetric septal hypertrophy. There was severe pulmonary hypertension, possibly from chronic volume overload, and her systolic blood pressure was 95 millimeters mercury before dialysis. The question is, was the patient in heart failure? Well, the question we have to ask next is, what precipitated the heart failure? The patient could have had high dietary sodium intake. Dialysate sodium might be inappropriately high, or they might be just non-adherent with dialysis treatment, for example, missing dialysis and shortening dialysis. The third factor was definitely an issue with Kalisha. Now, it turns out that dialysate sodium can sometimes be inappropriately high. If the pre-dialysis sodium is, say, 135, and you're prescribing a dialysate sodium of 140, that might stimulate a lot of thirst. Typically, we would prescribe a dialysate sodium about 2% lower than the pre-dialysis sodium in order to not stimulate thirst in these patients. So question is not what precipitated the heart failure, but who precipitated the heart failure. And I think that something which is hidden from our views is the physician. It's you. What do I mean by that? We are told that our 26-year-old patient requires 5 liters of oxygen, but now needs 8 liters. Did the physician ever think why a 26-year-old woman is requiring oxygen? Could this be the heart failure? Could this be the elephant that we are missing in the room? Could this be one of the thousands of patients on dialysis we are missing volume overload on, and they are going around with comorbidity that is quite easily treatable? What we are talking about in this patient is that she is volume overload. She has a volume state that is above what is expected in her system. She's above her dry weight. So how do we define dry weight? And dry weight is not definable as such because it's more an art than a science. But nonetheless, we will attempt to define and leave you with a concept. So when you return to your practices, you will be able to apply these concepts at the bedside. The question is, how do you define a dry weight? So Dr. Sinha and I defined this as the lowest tolerated post-dialysis weight achieved via gradual change in post-dialysis weight at which there are minimal signs or symptoms of either hypovolemia or hypervolemia. I've highlighted 3 words there: tolerated, gradual, and minimal. What do we mean by gradual change in post-dialysis weight? Well, gradual change avoids large and aggressive changes in post-dialysis weight that may provoke symptoms that lead both the nephrologist and the patient to decide that the further reductions in post-dialysis weight will be unsuccessful. For many patients and some nephrologists, this can be a lifelong conviction. In fact, many of my colleagues think that the dry weight in some certain patients can never be changed. What do we mean by minimal signs of hyper or hypovolemia? Well, it means that there is not a complete absence of signs or symptoms. For instance, raising the prescribed dry weight repeatedly in an effort to eradicate cramping may be futile. Some patients may always have cramping on hemodialysis regardless of how high the dry weight is set. And what do we mean by lowest tolerated post-dialysis weight? Well, it means that the prescribed dry weight is not an immutable physical constant such as patient's height. The dry weight changes and tolerability does change over time. The assessment requires frequent reevaluation by the nephrologist, and the attention to the patient's symptoms builds trust. So the tolerance to the post-dialysis weight has to be an ongoing process. So when do we probe dry weight? When the patient is too comfortable. For example, the patient tells you, never cramps, ever. Well, it may be because the dry weight is set too high. The patient has had a recent illness or hospitalization, say a pneumonia, patient was in the hospital for 2 weeks, hypotensive, never could remove weight on dialysis, comes back to the dialysis unit and now has lost weight. Unless you remove this excess volume, the patient will be in a constant state of volume overload. And sometimes when people are chronically volume overloaded, they will have low interdialytic weight gain. So small rather than large interdialytic weight gain can relate to high volume state.
I see many people write a blanket dialysis order of 2 to 3 kilo weight loss. I do not think that is a good practice in dialysis. The way you can probe dry weight is to record post-dialysis weight, for example, 72 kilos. Record pre-dialysis weight, for example, the next session the patient might weigh 76 kilos. Estimate the weight gain, which in this case would be 76 minus 72 or 4 kilos. Then you add to that a 0.2 to 0.4 kilo weight loss. So in this case, it would be a weight loss of 4.2 to 4.4 kilos.
So we tested this concept in the DRIP trial that was published more than a decade. In this trial, we took hypertensive dialysis patients and randomized them to a group in which we probed the dry weight, and the control group where we just saw the patients without probing the dry weight. The endpoint was the 44-hour ambulatory blood pressure monitoring that was measured at baseline, at 4 weeks, and at 8 weeks. We also measured the kidney disease quality of life at baseline and 8 weeks. We measured weight and hypovolemic signs and symptoms at every treatment. What we found was that the simple act of probing dry weight could reduce the blood pressure by about 7 millimeters compared to control. And this decrement in blood pressure was maintained over the next 4 weeks. So weight loss was only a kilo over 4 weeks, and the patients were on 2.6 blood pressure medications. So this reduction in blood pressure was greater than what has been reported with the denervation trials. So when you have to really think about improving blood pressure, don't think about removing the kidneys, but removing weight. Well, coming back to our patients, the dialysis prescription was set to remove 2.5 liters over 4 hours. I examined the patient. I increased the goal to 8 liters ultrafiltration over 4 hours. The nurse was appropriately nervous. I sat with the patient and got 7.5 liters removed with no symptomatic hypotension or cramps. At the end of the run, the patient was sleeping flat in bed. So why did I remove so much weight? Well, the patient was in pulmonary edema. This was an acute event, and failure to remove volume may have resulted in intubation. Blood pressure was 95 systolic, but a low starting systolic blood pressure is not synonymous with intradialytic hypotension, as illustrated by this case report. What do we do next? Well, order an echocardiogram, and the patient after dialysis had a normal systolic function. So the reason we do an echocardiogram is we classify heart failure by ejection fraction, reduced ejection fraction less than 40%, middle ejection fraction 41 to 50%, preserved ejection fraction more than 50%. Now, non-pharmacological treatment in all these three in dialysis patients is the same: diet, addressing the dialysate, and dry weight. And what we know now is that in heart failure with a reduced ejection fraction, in people who don't have kidney disease, the standard of care is using a angiotensin receptor neprilysin inhibitor, a beta blocker, MRA, and a SGLT2 inhibitor. It turns out that the last two can be thrown out in dialysis patients. SGLT2 inhibitors don't work in dialysis patients. The role of MRA inhibitors in dialysis patients is quite doubtful. Is problematic. This is a meta-analysis that shows that the risk of hyperkalemia is elevated threefold, and the effect is uncertain. Now, in the first-line drug that we use are beta blockers in all the three in the three groups. The second-line drug is recommended by some to be an ACE or ARB in patients with reduced ejection fraction, but that's opinion. We prefer to use amlodipine, felodipine in most of the other patients based.
I'm going to spend the next few minutes talking to you about a trial that tested
the strategy of using an ACE inhibitor to a beta blocker in patients who had hypertension and left ventricular hypertrophy to qualify for the trial. In other words, all these patients had echocardiograms at baseline, and they had to have left ventricular hypertrophy and hypertension to randomize. In other words, these are patients at incredibly high risk of heart failure because they have both hypertension uncontrolled by ambulatory blood pressure monitoring and diastolic dysfunction as measured by the echocardiogram. They had measurements of echo and ABPM at 6 months and at 12 months. They also had ABPM at 3 months. Our goal was to control home blood pressures to less than 140/90 by monitoring it every month, and the way we got it down was to add other antihypertensive drugs, but more importantly, pay attention to non-pharmacologic therapies, for example, adjusting the dialysate sodium and probing dry weight. Atenolol group got atenolol 25 milligrams 3 times a week. We titrated it up to 50 milligrams 3 times a week, and finally to 100 milligrams 3 times a week given after dialysis. Now, home blood pressure monitoring showed that the home blood pressure monitoring was between 5 to 10 millimeters higher throughout the trial. The question is that did we not do our job? Now remember, the goal blood pressure in both these groups was less than 140/90. We did that by titrating the dry weight down. In the atenolol group, the dry weight was pretty constant. In the lisinopril group, we got the weight down quite substantially. In fact, between group difference in the two groups at 12 months was nearly 3 kilos. Recall in the drip trial, it's only 1 kilo. And at 2 months, there's already a 1 kilo difference between groups in lisinopril. So you would think that in 2 months, you would expect a 7 millimeter reduction in lisinopril group just by volume reduction alone. The goal blood pressure in both groups was less than 140/90 by monthly home blood pressure monitoring. As you can see in this graph, atenolol group, we had to increase the blood pressure medications, but the number of medications that needed to be increased in the lisinopril group was even a lot more. At the end of 12 months, nearly half a medication more was needed to control the blood pressure to less than 140/90 in the lisinopril group. So the trial was terminated early because there was a clear signal for CV safety analysis. And it turns out that atenolol group had 14 subjects who had 18 cardiovascular events compared to lisinopril group with 26 subjects with 40 events. We plot the events per 1,000 patient years, about 24.6 in atenolol group, 58 in lisinopril group, and the incidence rate ratio was 2.36. So more subjects had serious cardiovascular events. All-cause serious adverse events were nearly 1.5 times more common in people on lisinopril group, more hypertensive crisis, more hyperkalemia, where BP values were different between groups. Is this a flaw in the study? Atenolol-based antihypertensive therapy was associated with better systolic blood pressure after 2 months, despite a greater weight reduction in lisinopril and greater antihypertensive drug use in the lisinopril group. This is not a flaw with the study design or conduct. It just tells you that atenolol works better to get the blood pressure down. If you use atenolol to treat hypertension, you don't have to work so hard. So coming back to the case, the patient arrived in the emergency room with shortness of breath. She was dropped off by an ambulance. Why? If you're not addressing the social determinants of health as a nephrologist, you're not doing your job. This patient in particular points out the social factors. They are deeply connected with any patient with heart failure, but particularly those on dialysis. In fact, we can go out and say where the patient lives is more important than most of the medical issues that they might have. The zip code may be more important than the genetic code. And we are having a patient here who was homeless, lived in a shelter, did not have transportation, had no way to regulate hunger and food insecurity, likely had access to only high sodium foods, low health literacy, reduced ability to self-care, and reduced treatment adherence. An appreciation of the social determinants of health may at least allow addressing. Here's an American Heart Association scientific statement from this year that puts forth guidelines, a beautiful case study that goes with the scientific statement that I would encourage you to review. So in conclusion, heart failure is a clinical diagnosis based on symptoms, signs, imaging, and response. The 3 tenets of treatment of heart failure are diet, dialysate sodium, and dry weight. The doctor is a risk factor for the dialysis patient because he or she is not as smart as the kidney. Probing the dry weight is gradual, depends on tolerance, and it strives to minimize symptoms, not to abolish them. Probe when the interdialytic weight gain is low or the patient was recently ill. ACE inhibitors are for patients before getting to dialysis, atenolol for when they are on dialysis. The social determinants of health are pervasive. If not addressed, we are not treating the whole patient.